Welcome to Healthcare Redefined, advocating for aging adults and their families. Hi, I'm Pam.
And I'm Linda. We're registered nurses and board certified patient advocates.
Each week we help family caregivers feel less overwhelmed and more confident, one step at a time.
Well, this month's theme is preparing for the new family caregiver. And today's episode is a must listen. If you've ever thought, I'm doing everything, surely there's more support out there.
This is episode 10, How to Get More Help from Your Clinic, a new caregiver's guide. And we're interviewing an RN that we both know very well, Viki Droegkamp.
Viki is going to walk us through how to take full advantage of the services your primary care clinic may offer.
Every clinic is a little different. So, what one clinic offers, another clinic might not offer. But in general, we're going to cover the resources that can make caregiving easier for you, like care coordination, medication help, referrals, and possibly some social work support.
Yeah, and those things are really important. And we're going to talk about how to use online tools such as MyChart to stay organized and in the loop.
So if you're wondering how your primary care clinic can make your life easier, this episode is for you.
So let's jump right on in there and get with our guest.
Okay. Let's set the stage here. So, kind of a quick caregiver reality check. You shouldn't have to coordinate everything alone. And we also want to clarify too that this is the primary care clinic. This is where your regular doctor, your preferred provider is, and this should be the hub for coordinating all the care, not just going in for annual visits. And last thing I want to mention is, services do vary by clinic, but we're going to talk about some that are more common options that you should at least ask about.
So, Vicky, I'd really like to start with the first question for you on who is the best point person for care coordination in your clinic or in most clinics that you're aware of?
At most clinics, when you call a clinic directly, usually at my organization, we call it a PSR, patient service representative. And even though they manage check-ins and whatnot at the clinic, they can do everything from like answering questions, scheduling appointments, pending lab orders, things like that. So by just directly contacting the clinic, they can usually either help you themselves or they can connect you with a nurse or whatnot that can better serve you.
So basically, calling the clinic and saying, can I speak to the care coordinator or someone who can coordinate my schedule or my appointments? Would that be
Or
correct?
yeah, or Vicky, would this be someone who's generally answering the phone at the clinic when you call?
Yeah, they're our first point of contact when a patient calls the clinic. They're the first ones that answer. So then they can figure out if either they can help you or they can direct your call to somebody that can.
Okay. Are there like nurse care managers, care coordinators, or case managers on site that can help with coordination of care or with specific questions that individuals may have regarding appointments or treatment regimens?
Yes, we do, but they're spread out. They cover multiple clinics in our area. So it might take a little bit to get a hold of them, but it is very possible. We also have social workers too that can help you as well.
Okay. So how would they message the team? I mean, would it be better to call them or would it be better to use like the MyChart or an email system to get them to answer me quickly? And if I do call, usually what is the turnaround time for response?
So it depends on if the patient is an established patient with the clinic or not. If they are established, my chart would probably be the best option. If they're not established, then they can call the clinic and talk about next steps and can have somebody connect with them to help them. And then turnaround time for my chart. We typically say if you send a message, we as nurses have around 72 hours to send a response. It depends on, we have frontline people that identify if it's a high priority or not. So we handle those high priority messages first.
Okay, so what would be the best way to handle or request like a refill for medication? Because I can tell you just from personal experience with my own parents, they wait until they have one pill left to call for a referral. So what's the best way to request for those refills or forms and or referrals? And what is the turnaround time on things like that?
Yeah, so for MyChart, that is probably the best option to request a refill. Now, if you request the refill through the MyChart, there's no need for you to send an additional message that kind of just like clogs up our portal. If a lot of people don't realize that medical assistants and nurses can refill medications per protocol. So if it's a standard med and it's not a controlled med, we can refill that. And typically we have around 48 hours to 72 hours to refill it. Now, if it is a controlled, we have to send that request specifically to the doctor. And then they have to look at things like the PDMP and whatnot, which is like the controlled substance database, at least for Wisconsin, to make sure everything's up to date. And then those turnarounds can be like a week because there's more involved. Yeah.
So, so Vicky, for our listeners that may not understand it, could you give some examples of what controlled substances would be?
Yeah, so controlled substances are those stimulants for like ADHD, so the Vyvances and the Adderalls. Otherwise, for like more like geriatric populations who are in chronic pain, they might have like gabapentin, which give or take, depending on the clinic, that may or may not be a controlled for nerve pain. Otherwise, like the oxycodones or the Percocets or Xanax, those are all controlled medications. So then there's more strict rules.
All right. So, Vicky, let's talk a little bit about some of the core clinic services that caregivers often don't realize that they can use. So, at your clinic, do you have like a triage nurse or if you are having some kind of illness or ailment, I mean, is it worth calling the clinic before you go to urgent care or something like that?
For sure. So a lot of people are unaware that in most provider schedules throughout the week, they have acute spots and then they have TCM appointments, which I'm sure we're going to talk about later, but they can fit you in even if your provider seems very busy throughout the week for those things that are acute. So whether like you're having the flu or COVID, maybe those things that you've been having symptoms for a week or so and you're stable and you just need like a minor test, whether it's like a COVID test or a flu test, you can go to your primary care provider and get those tests completed and then get treatment if needed. So as long as you're stable and you've had symptoms for a couple days and it's not life threatening, maybe if it doesn't require imaging, then you can go to your primary care provider. But if it's a little bit more serious, like a sprain, or whatnot of an ankle, then you could go to urgent care. You could go there for like UTIs as well. But if it is like shortness of breath, confusion, stroke-like symptoms, blurred visions, slurred speech, then that's the time that would warrant the ER if it's critical and you cannot wait.
And and I'm sure this triage person, if someone called in with symptoms that if they thought it was something that needed to go to urgent care, they would just recommend them that they would go.
Yeah, so I work as a triage nurse as well. I kind of switch roles. So we have protocols depending on the patient's main symptoms. And then we'll go through and ask them a series of questions. And based off of their responses, helps determine if they need to see their primary in 24 hours, if they need to go to urgent care, or if they need to go to the ER. So it gives us recommendations on what they can do or should do.
Perfect. What about those post-hospital questions? What Linda and I ran into a potential client that was set up for wound care from the nursing home, ended up they hooked him up with a provider that wasn't covered under their insurance, so he went without wound care. What about these post-hospitalization questions that could come up? Is the clinic an appropriate place for you to try and figure those things out?
For sure. So there's a difference between ER follow-up and then a TCM or transitional care management appointment. Those are usually if somebody is admitted to the hospital and they stay for more than 24 hours, then they require like a TCM in usually 7 to 14 days post-discharge from the hospital. Whereas an ER follow-up is just if they were in the ER for a couple hours, they were discharged. Um, then they could make an ER follow-up appointment. However, we do recommend the TCMs and the ER follow-ups, and at that time, the provider can look at the medications that were prescribed in the hospital, determine if they need refills provided. They can see how well the person is recovering, and then they can also decide next steps, like if additional wound care orders are needed or if additional referrals are needed to help with their treatment plan. So we do recommend those follow-ups, and they are very helpful, especially to loop your primary provider in who has probably seen you for many years.
Gotcha. That's a great comment. Moving on to medication support. So Linda talked a little bit about what's the refill process. So I don't want to go over that again. But how does the clinics handle, like if you're like, for example, we have a client who uses a medication Trelegy, which is very expensive for her COPD. How does that work with prior authorization? Does the clinic help with that?
For sure. So I've seen it where on both sides of it, where we sometimes we'll tell the patient to contact their insurance and we'll give them a list of medications that would work for their condition. And then they could ask the insurance company which ones would be covered with their diagnoses. Or we have resources specifically for DME supplies. It's called Parachute that can help us. We just fill out a few questions regarding the patient, and then it tells us what medications and what supplies are covered through their insurance. So it's one of two ways, really. And then once we figure out what may or may not be covered, we can just initiate a prior auth, depending on which is basically seeing if the insurance company will cover it. So if they don't, we'll just find a comparable medication and then we'll retry the whole process again. Depending on the medication, though, the time for it to get approved or denied can vary. Usually at the beginning of the year, everybody's trying to get their medications approved. So specifically like weight loss drugs, those are anywhere from like 7 to 8 weeks turnaround for prior auths. But we do assist with them. At least at my clinic, we're very accommodating. If something's denied or if you need an alternative, we will usually handle that. I don't know if that helps you.
Gotcha. And that's great because that really kind of leads into the last part of that medication question I was going to have is we run into, now that the new anticoagulant medications, like the new medications that are very costly for that. So if, say, for example, they don't approve one, I mean, is it pretty common for the doctor, okay, well, maybe we'll switch and use a different one? And I mean, are the doctors pretty accommodating for that?
They are, because they want their patients on these medications. So there's usually an equivalent or an alternative medication. So if we need to go down the list and keep prescribing different meds and initiating prior auths until one's approved, we'll do that.
And I don't think a lot of people understand too, like the Eliquis comes to mind.
Mm-hmm.
And what's the other one? Eliquis and
Coumadin, warfarin,
no,
Plavix.
Linda, help me out here.
Yeah, help.
It's the other one, the Eliquis and the
Lovenox.
no, it's the other new oral one that doesn't need any blood work. Eliquis and oh, I'm really drawing a blank there. Well, anyway, there are two of the newer ones, so they're still under patent, so there's no generic. And
Yeah.
so, but sometimes the clinics will cover one of them and not the other. So
Mhm.
that's it's good to know that you can reach out to your physician, because I know sometimes too that sometimes the generic is less expensive than the trade name. So how does the clinic, I mean, does the clinic normally use a generic, or how does it work?
It totally depends on the availability, and then patients' preferred pharmacy as well. Some do, a lot of the geriatric population, they do mail orders. So that reflects the quantity that we order. We can't order anything less than a 90-day supply at a time for most of them to have full insurance benefits.
Yes, I was just going to say it just popped in my mind that it was the Xarelto and the Eliquis. So those were the two. So thanks, Linda, for reminding me on that. So
yeah, so it depends on availability, pharmacy, whether it's like a mail order or not. So it depends on a lot of factors. But a lot of providers are accommodating, and they have done peer-to-peers with insurance companies. They've talked to insurance companies to appeal decisions if medications were denied. They've written letters, things like that, to get meds that were previously denied covered if it's absolutely needed. So I've seen them go above and beyond and do a lot more than what we think a provider would do in regards to medications.
Mm-hmm. So would it behoove us to share with our audience that if they have any questions, or that, I mean, would it be prudent for them to ask if they could order the generic?
Yeah, if that is, yes, they can absolutely ask if a generic is available on that. There is actually in the MAR, the medical administration record in Epic that we use, there is a note to pharmacy that we can put in, and we can say like dispense as insurance preferred, which is usually the generic. But if they don't want generic, if they want name brand only or whatnot, we can say only name brand, and then we can switch the pharmacy.
Yeah, I've seen that actually with a couple of my clients that it's right there that they can check a box saying may okay to use generic, or they'll say no generic, you cannot use generic, must use brand name.
Because they have different fillers. Yep.
Yes.
So
Hmm.
it really depends on the pharmacy, the med, the patient. A lot of things go into it, but we are able to order both.
Gotcha. All right, let's move on to referrals and care navigation. We basically touched on, and I know we'll talk about a little bit more about the transitional care nurses, but how does it work if the primary care provider recommends maybe a specialist or x-rays, whether it's therapy, home health, walkers, or oxygen? Does the clinic usually take control and manage that?
Yep. So we can put in the order, either the nurse or the provider, or the nurse can with the provider's order, like verbal order. So we put in like a service to, whether it's a service to ophthalmology, service to cardiology, whatever it may be. So we put in that referral, and then how my clinic does it is we have a CRS, or a certified referral specialist, for each clinic. So we just route that order or referral to her, and then she'll reach out to the patient to get them scheduled with any of the specialty providers. So I'm not sure how every clinic does this, but that's how my clinic does it. So
And-
we contact the patient to schedule.
Gotcha. So to take that one step further,
Mm-hmm.
when you're looking at, what companies to use, or, maybe a home care agency, does the clinic, I mean, are they going to check to see who your insurance, is a preferred provider for?
Yes, they will. And then with my organization, they actually have their own home health company within it. So that is majority of the time what they recommend, because that's covered if they have like the same organization provider. However, we do have other partnerships with other outside home agencies that they'll work with as well. So, but yes, they do contact insurance to see which one's covered.
Perfect. All right. And now let's move on to the last portion of what I wanted to talk about. Or actually, we have a couple more things. But what about chronic condition management, such as diabetes, congestive heart failure? I mean, do you have certain programs, or even though that there may be specialists involved with diabetes or congestive heart failure, how does a primary care clinic, support these chronic diseases?
Yeah, so specifically with diabetes, we have a diabetes educator that offers group and individualized sessions. Depends on how new the patient is to the diagnosis. Even if it's a chronic diagnosis as well, they can get referrals put in to attend these like educational groups to learn more about it. And then just in regards to like managing it, we have appropriate follow-ups with the patient, and we can adjust medications, things like that. So there is plenty of like educational things that are offered.
And so,
That makes sense.
does the primary care provider, are they the ones that usually order the routine labs? I mean, who kind of keeps all these balls in the air, even when they're seeing specialists?
Typically, it is the primary care provider. Now I know specifically United Healthcare, I think it's just this year we've seen an uptick in every specialist a patient sees starting this year, we need a brand new referral for that year. So if they've seen the cardiologist for 10 years, previously one referral would have been okay. Now every year that they're continuing to go to the cardiologist, they need a new referral. And that's specifically with United Healthcare. I'm not sure if it's with other insurance companies as well, but I know United Healthcare specifically requires all referrals to come from the primary care. So I'm not sure if that's every insurance, but most of those labs and everything, pre-op appointments, things like that and labs and referrals come from the primary care.
And I'm just going to throw a
Mhm.
plug in there. And
Yeah.
Linda, if you have anything you want to add here, I just want to say how important it is for you to be familiar with your insurance, because whether any of us like it or not, the insurance companies are driving much of the healthcare system. And so if you're not
Mm.
sure what your insurance company will approve, or what their process is for you to get the healthcare that you need, you really do need to become an advocate for yourself. I mean, obviously, Linda and I, our services help, or your clinic can help, but you really need to have a consumer awareness of what your insurance company will, what their processes are to get approval for anything that you need from your primary care doctor or from a specialist.
Yeah, and
Yeah, and most insurance companies will send, anyway, most insurance companies will send their consumers their benefit package or benefit handbook. The problem is a lot of people don't take the time to read it or read the fine print. And a lot of the language may be very confusing for people because a lot of it is set in medical terms. So they really need to look at that. And if they have questions, they really should contact their insurance company to make
Mhm.
sure that they understand what is allowed under their plan so they're not blindsided. Now, there is a Transparency Act that's out there with hospitals and clinics and that to basically tell you what it's going to cost for certain procedures and or an ER visit or for certain tests, but that really hasn't hit home to a lot of consumers yet. So I really think that, making sure that you're aware of what you are actually able to get paid for under your insurance and what they'll cover is really important. So it makes Vicky's job probably a lot easier if the consumer does know what the insurance is going to cover.
Yeah, we
That
are willing to contact insurance. I know our clinic is the nurses because we have like provider lines that we can contact insurance through, and it's a lot less of a wait time when we call them versus, our patients. So we are able to do it. It just depends on the individual clinic. But another thing is just like it depends on if you're Medicare or if you're a Medicare Advantage plan as well, because if you're Medicare Advantage, they can cover labs anytime throughout the year. And then if you're just straight Medicare, it has to be exactly 365 days after certain labs. Otherwise, they're
Mhm.
not covering it. And then another big confusion is there's Medicare wellness visits that are recommended, that are covered every year. And those are different than physicals. Most of the time, those are in place of physicals. So that is another thing that most patients when they're on Medicare they get confused about because they think they're coming in for a physical and it's really just like a welcome to Medicare or a Medicare subsequent visit, which just is like a hearing and a vision test on your first one, and then following subsequent visits are just like a little memory test. So, yeah.
And that's really important because I want to stress because a lot of consumers, when they go to those Medicare annual, checkups, they say, well, they didn't listen to my lungs or they didn't do this or they didn't do that. And so
Hmm.
that's not really what the purpose is
Right.
of those visits, is it?
Mm-mm.
Yes.
Okay. So we just
Hmm.
want to make sure that we clear that up because a lot of, people will complain about that, but it's because they don't understand the purpose of
Hmm.
that Medicare annual wellness
Yeah.
visit. So,
Yeah.
Vicky, let's move on to vaccines. So, how does your clinic or how do clinics usually, I mean, do they keep track of vaccines? Do they recommend? How does that work? How does someone know when they're due for a vaccine?
Yep. So in Wisconsin, we have the WIR or the Wisconsin Immunization Record. So as long as you've gotten your vaccines in Wisconsin and you're from Wisconsin, we can see that. If it was in a different state, we have a harder time of seeing that. So we just ask that you bring in a record of it, depending on what state you're in and what state you're seeing your PCP in, your primary care provider, so we can update that specific record. And then in regards to when you come for an appointment, at least how we get the charts ready when we pre-chart on a patient prior to seeing them, we have care gaps that come up. And this basically notifies the care team like this patient is due for their mammogram or their colonoscopy or like this vaccine. And if they're on Medicare, we just recommend they go to the pharmacy for all their vaccines because they're covered there for sure, where they might not be covered in the primary care office. So it depends on what the vaccine is. COVID and flu, I know, are covered in at least my clinic setting, but if it's RSV, Tdap, or pneumonia, those are not pneumococcal vaccines. Those are not covered for those that are on Medicare in my clinic. So we just recommend that everybody that's on Medicare goes to the pharmacy just to prevent any possible, insurance not covering it. But yes, our as long as our health record or the patient's health record is updated, we can see when their last times they had vaccines were and then what are recommended. So,
Gotcha. So then, just as a side note, if someone's moving or they're, moving to another state or maybe they're traveling and it may come up as far as vaccines, they really should keep a record of that with them.
for sure. Yeah, because at least in Wisconsin, the only records that we can update with the verbal without any proof is the COVID and the flu vaccine. Anything else we cannot take a verbal for. We need actual documentation that the person received it in order to update their record.
Perfect. All right, so let's move on to my last topic for this segment of the podcast, and that's going to be looking at forms and documentation. What how does the clinic help when you have family members that say, we're talking about family caregivers, so FMLA may come into question, or disability, or they need a note for work or for school, paperwork that's needed for assisted living or driving concerns. What are some of those forms, and how does the clinic help in that with that type of documentation?
Yeah, so if the patient is relatively close to the clinic and they're able to, we prefer them to just drop them off at reception. We'll have the nurses and the provider look at it. We'll see if it's something that we can accommodate them for, and then we will either fill it out or ask that they come in for an appointment if it needs more documentation, such as like a disability parking sticker, things like that. We do ask that we see the piece of, or the form prior to just saying yes or no, we'll fill it out, because it really depends on what the form says. If you do not live close to the clinic, you are able to attach documents on MyChart, and you can just send it to us and we can look at them and print them off that way. Once the forms are completed, we can upload those to the patient's portal and they have access to them that they can print off. Otherwise, we can just print off a copy if it needs like a doctor's signature, and we can put it up at reception, and then patients can come pick it up as long as they just show an ID. So it really depends on what the form is. We are very accommodating on most forms. If it is something that requires more assessment, then we'll just ask the patient to come in for a visit
All right,
to
and
help complete them.
on this topic too, what is the clinic's role? This comes up a lot with Linda and I with our aging clients. What's the clinic or the primary care provider's role when it comes to driving? How does that work?
Driving as what do you mean?
Well, I'm sorry,
Like,
maybe like if it's time to maybe take away their driving privileges, what kind of things do the primary care physician do? Do they communicate with the DMV? How might that work?
yeah, so they typically, if it is a concern, yeah, so most of the time it's usually a family member that will send us a message in MyChart that says that they're concerned about their mom or their father driving, and then we can bring them in for a visit. We can do like a vision test or whatnot. We can assess their needs to see if they do in fact need to maybe lose their license, and then that can be a conversation that the provider and the child can have with their mom or dad or whoever the patient is, if that's what they want. So as long as the child, like, if so, yes, so if the doctor does feel like the person should not drive and they're not giving up their license willingly, they can contact the DMV, and the DMV can require them to come do like another vision test or whatnot. Or they could just simply revoke their license if there's enough medical documentation. If they had like a stroke with significant symptoms or delays or whatnot, and they are harmed themselves or others, we can take their license.
Yep, I would say common for Lynn and I
Mhm.
too. It comes up frequently with clients that maybe have some form of dementia that they don't feel is significant. They say they can drive, but then there's cognitive issues on whether or not. So the doctors will look into that and make that determination. Okay. I think that's what I have for my section. Linda, do you have some questions for Vicky?
Yeah, actually, I wanted to get in with Vicky on discussing, some tools that people can utilize to be able to have good communication with their primary care provider. And one of the biggest tools that I see is the MyChart tool that's used. And I think it's personally, I love it because it's right there. I can see things, I can see my lab results, and you can see it in a way that's easily readable, and it's more set for people who are not medical professionals. So you can easily determine what those test results are saying. And you have a way of communicating if you're not sure what it means on that email. So can you go through a little bit about how someone would get access to that, or proxy access if their loved one is not able to actually understand or actually able to understand how to get into that system?
Yeah, so when a patient comes for their appointment, at least, so Epic is the charting system that a lot of people use. It's what my clinic uses.
Hmm.
So right next to their profile picture on their chart, it has a little circle and it says if it's blue, it means they're not active on MyChart. If it's green, it means they're active. So if they're not active while they're at their appointment, we can click on it and send a one-time code to either their cell phone or their email address that can help them get started with an account. And then if they are active or whatnot, we can have, there's within the MyChart, when they're logged in, there is a like sidebar that says like access Proxy or get access or whatnot. And then they can add whether they're a minor or if they're like a geriatric patient, they can add whoever they need to be a proxy, and they can send MyChart messages on behalf of the patient. So yeah.
To be clear on that, Viki,
Yes.
if they set up a proxy, I mean, the permission, does that need to come from the actual patient?
Yes, but it depends on if there's like a active power of attorney or not as well. So it depends on what the advance directives and the power of attorney is too. So most of the time, yes, unless they're deemed like,
Right.
Mm-hmm. Incapacitated. Yes. Mm-hmm.
Incapacitated. Mm-hmm. Yeah, because that's what I've seen also. I've seen that it can be deferred to them, like at the doctor's office. They can say, well, no, I want my daughter to have access. I don't want to deal with this. I don't know how to deal with it, and I'm not dealing with it. So right then and there, they've got that verbal consent to be able to do it. If under other circumstances, I have had where they have asked for that healthcare power of attorney paperwork to be able to allow proxy access to this MyChart. But it's a great tool. So what are some of the things that people can find on the MyChart? I mean, I know what I see, but what are some of in the bigger picture, what are some of the things that individuals can find on MyChart?
So I think the biggest thing besides like the basic like lab results and after visit summaries and diagnoses and things like that, medications, bills, like billing history. You can get educational pamphlets and things like that in regards to your conditions. There's videos, there's QR codes you can scan. With at least pediatric patients, there's games they can play, kind of educating them on what they are diagnosed with. So there's just a lot of resources. But I think you can schedule appointments. The biggest one, though, I think, Linda, you already touched based on besides requesting refills, is the MyChart or the messaging. So on there, you can send a message to the patient's care team, and typically it's the nursing staff that responds to those. Unless it's something they cannot help with, then we'll forward it to the provider to respond. But those are things where you can give us updates on like blood pressure readings or blood sugar readings, or if you've had a cough for a couple days and you're concerned about it, or if you have emergency symptoms, I wouldn't recommend using MyChart to update us like, oh, I have confusion or balance problems. We would most likely get a hold of you and triage you, but that's probably not a good way to use it. But yeah.
Viki, I just have one question on that. Oftentimes what I've run across with a lot of our clients is they feel that they don't need any other information except what they get from their visit summary. Could you explain the difference between the visit summary and the actual doctor's note?
Yeah, so at least I know on my personal MyChart, when you click on the AVS or the after visit summary, there's a down caret and you can actually read progress notes. So I'm not sure if that's on everybody's MyChart. I'm sure it is. So you can read those to get more in depth about. So if you go in for a physical, it has every body system that they did an assessment on and their findings on it, versus the after visit summary just addresses like your BMI, your most recent vital signs, so your blood pressure, your pulse ox, your height and your weight, any lab tests that might have been ordered, and then like follow-up recommendations. So it's very simplistic and it's a summary of everything they did, whereas the doctor's notes go in depth. It talks about more medication changes, recommendations, things like that. So
Yeah, and I've noticed on some other systems, I should say, is that oftentimes the quickest way that you may get to the doctor's note is actually to go to your past visits. And I see some and some other systems where you can click the actual doctor's note by going to your past appointment. So there's usually a couple of ways that you can access those doctor's notes, but just wanted to say that there is a big difference between the after visit summary and the doctor's note.
And you can use those doctor notes as cues for questions for your next visit or for cues to, finding out more information or to hand over to a specialist who you may be wanting to get a second opinion from. So those doctor's notes are very important. Sometimes though, and I have seen this in these doctor's notes, the note is written with a lot of medical terminology. And unfortunately, a lot of the lay individuals that are getting this information don't have a good understanding of the terminology. So a lot of times their perception of what's written in those notes is maybe incorrect or not consistent or not concise. So if they don't understand what is on that doctor's note, they really do need to make a phone call and talk to the nurse or talk to someone about what they don't understand, make another appointment, print that out, write their questions next to it and say, what exactly does this mean for my follow-up? What do I need to do to deal with this? And what exactly are you, and I've even had patients say, what exactly are you talking about? I don't understand any of this. So they're very good it's very good information, but you need to be able to understand what you're reading. And I did ask a provider at one point, why when you go for these visits, why are you only giving a visit summary? And that was for the very reason. They said, well, this is just a point in time. This visit summary is about this visit, this specific point in time. It doesn't deal with your whole health picture, the big umbrella. So if people want that big umbrella, as Pam said and you said, they really do need to dig in and look for those doctor's notes and that previous medical history. So what would you say about what do you think? Do you have a referral status in there? I mean, if they were referred to outpatient physical therapy or to an ophthalmologist or to a cardiologist, would that show in the MyChart and it would give them the name and any information they need for further follow-up with that?
Yeah, it should, if a referral is placed at that visit, it should come up in the MyChart as like needing an appointment or schedule an appointment. Most hospital systems and organizations, they'll reach out to you if it's a specialized visit, but if they don't, it should pop up as like a task not completed, or it might look different for each person, but it should show up if a referral is placed with a phone number that they can call to schedule.
Okay, so can you give us an example of some of the educational handouts that someone may find on a MyChart?
Yeah, so for cholesterol, it would tell you healthy diets to follow if you want to lower your cholesterol levels. In regards to diabetes, it would tell you similar things for dietary restrictions that you might need to start following, exercise recommendations. It could also teach you the importance of checking your blood sugar, twice a day, 3 times a day, depending on what the doctor recommends. It could also, teach you like breast exams. There's a wide variety of resources on MyChart. So, and if you need more, they can just send a message and we can get them more.
So, what would your recommendation be to someone who is a caregiver who is using MyChart in regards to communication? What would you recommend in how they verbiage their messages, and what they put in those messages?
So I would just keep them short. As a person that responds to these messages every day, I really do not love reading paragraphs. So just like short, sweet, and then always have the ask in there as well. What are you asking for? Are you asking for a repeat lipid panel or cholesterol panel, or are you looking for an appointment for a acute problem that just started, like, I don't know, UTI symptoms? Like, tell us what you're asking for. Most of the times we will give you what you're asking for, but just, give us some background and then why you're asking what you're asking. But I think one of the biggest mistakes is that like caregivers usually, like, so if it's kids, they're usually taking care of mom and dad, and they'll be asking about mom under dad's chart. We're not supposed to be typically responding to another patient's concerns, even though they might be married or whatnot, because every message that a patient or the proxy sends is documented as a different encounter, whether it's a telephone encounter or e-advice encounter or MyChart encounter. So we just don't want to get patients mixed up, if that makes sense, within one patient in one chart.
No, that does make sense. So can you tell us when would be considered an urgent issue where they should call you, or what would be a non-urgent issue? Can you give us an example of what that would mean for like a message?
Yes. So non-urgent would be like COVID symptoms, as long as you're not having, extreme like shortness of breath or things like that. If you're just having, some general body aches and I don't know, a stuffy nose or fever, those things that could wait a day or two to be seen or addressed. Where a urgent issue would be like my lips are swelling or shortness of
I can't
breath.
breathe.
What?
I can't
I
breathe.
can't breathe. Like those things, you should just go to the ER. But if, we do have some of those patients that are a little more stubborn that would like us to tell them to go to the ER before they'll go to the ER. So, those life-threatening, urgent, I can't wait, not
Mm-hmm.
stable,
Mm-hmm.
balance difficulties, slurred speech, those things.
So a fall, if someone called about their dad and said, my dad just fell, that would rectify like an urgent call. You wouldn't want a message on that. You would actually want to call on that.
Correct. Especially if they're on blood thinners as well. Whether or not they hit their head, that could be a critical fall. So we'd recommend that them calling. Now, if it was just a little like maybe slip on the ice and there's no physical, they just got up and there's no physical
Injuries.
injury, maybe that could be like urgent care.
Okay.
Yeah.
Okay.
All right.
All right. That's basically what I have. Pam?
Yeah, we're going to move on to maybe some other resources that the clinic might have. So, Vicky, I know we talked a little bit about this beforehand. So, you mentioned that you had a social worker that covers multiple clinics. I know in our area, each of the clinics have a social worker. What are some of the types of things that the social worker might help a patient with at the clinic?
So they can help those that are unhoused or facing homelessness, those that are on a fixed income that might have difficulty, cover or paying for their prescribed prescriptions. They can also help, finding like whether if they're like homebound and they need like mobile wound care, they could help set that up. They can also help with like mental health concerns. Basically, they're just your support system or person to help you. They can help you with a lot of things, more so.
So
Yeah.
they basically will help like with a lot of community resources like care support groups, things like that. Okay. So would the social worker, so what would you utilize a social worker, say, if a family member calls you and says, you know what, I'm burned out, I can't do this. You need to put my mom or dad in a nursing home. I can't do this anymore. So would they assist with trying to find placement for a loved one?
They can, yep. They can first, usually it's like respite, so care 72 hours, whatnot, just to give the caregiver a break. And then if they need to find permanent placement, they will help with that as well, whether it's memory care, assisted living, things like that.
So, and one of the reasons why I bring that up is oftentimes, and Lynn and I have both worked in the ER, and oftentimes a family member will come in and drop a loved one off, and there's really not anything wrong with them, but they say, I just can't do it anymore. So what you're saying is they really should reach out to their clinic for some help.
Correct. Yes,
Okay.
for sure.
Do the social workers, as you mentioned, they help with maybe some finances if they're having trouble, when would a social worker step in as far as maybe not paying their medical bills versus working with the billing department? What would be the difference there?
Well, you got to ask for help. Like they're not gonna typically reach out to you. You're going to have to, whether it's the caregiver or the patient, reach out to them. And as long as you reach out to them to let them know you're having financial concerns or whatnot, they can usually figure out some solutions, whether that's like
Hmm.
good RX coupons. Sometimes good RX coupons are cheaper than using your insurance, depending on the medications. There's a lot of grants that they can help get for patients in regards to whether it's like medical supplies, like blood pressure monitor, like cuffs or things like that. So I would say reach out to the social worker prior to having any like severe, like falling behind in paying your bills, they're
Hmm.
more likely to be working with you prior to, because it's really hard for them to recode. We've had patients try to ask us to recode visits, and obviously we can't do that most of the time because it's, fraud. So, yeah.
Right. Yep. No, exactly. And now in your and we talked a little bit about this in your system. Do they help with advanced directives at all?
They can, but the biggest thing, we have packets. That's like when patients get annoyed with if they don't have them done, we ask them at every visit, do you have them done? Will you bring us a copy? If not, we have folders of every single thing that they might need to fill out. And then we have people that they can call, such as a social worker, if they need more in-depth like answers to questions that they may have. We've so yes, they most definitely can help with that. But the biggest thing is you need to have people like witnesses to sign them. And we've had a lot of patients need two signatures and they bring them in thinking like the nurses or the doctor could sign them and they can't. They could be like your neighbor, but we cannot sign those for you
Yeah, that's
as a healthcare
yes,
provider.
that is a really good point, and people need to understand that, the witnesses, the social worker, and I've seen instances where the social worker can sign, but a nurse or doctor cannot, and a family member cannot, especially those that may be mentioned on the advanced directives, they can't sign as a witness. And so I like to bring this up because a lot of people think that you have to go to an attorney, and pay for the advanced directives. And it really can be, a free or low cost option for you to be able to get help with these advanced directives. So what we try to do with these calls too and these podcast episodes is to, reduce barriers, for everyone to be able to get help. So thank you for that, Viki. We talked about placement support. We talked about it going in a nursing home, but obviously you could help also with assisted living or memory care or home care services. And I think we've talked a little bit about that. So does a family member need a referral to the clinic social worker? How would one get a hold of it, or how do they ask for that?
Typically, they can just call our clinic and ask the front desk for their number, or they can send like a secure chat to the nursing staff and we can put in the referral for them. Like it's not anything physical. It's not a physical referral that they need. As
Hmm.
long as they're an established patient, they can just literally call the clinic and we can have them get a hold of them.
So
Yeah.
before I move on to Linda, one last thing that kind of cropped up in my mind, how important it is for someone that say is moving, changing locations, how important or what kind of a priority is it for them to get set up with a primary care physician as soon as possible?
It is very important. We want to, ERs are for those that are very sick and urgent cares are for people that have, less severe symptoms but might not be able to wait a few days. But your primary care provider is the person, your go-to person. They can put in basic lab orders for you. Some of them might, order a urine sample for you if you're having UTI symptoms without you even being seen. You can just come to the lab, provide the sample, they'll treat it without seeing you. So having that relationship with a primary care provider is very important as they're going to be the one person that knows you the best. They can help you with the most resources and hopefully they can just help prevent you from going to the ER and they can, treat symptoms before they get worse and progress. So,
Thank you for that. And just, yes.
mhm, yeah.
And just a side note too, again, check your insurance. Make sure you're choosing a primary care provider that is in network with your insurance company. So with that, I'm going to turn it over to you, Linda.
So, Vicky, just to, as we're getting closer to the end of this podcast, I just wanted to go through a couple things here in regards to some complex cases that the clinic may see where you may need to have help from other entities. So, can you speak a little bit about what transitional care means and what do they look at in regards to transitional care?
So, transitional care meetings or TCMs are those that we typically recommend within 7 to 14 days of a hospital discharge, just to prevent readmission. So, in regards to that, they'll just discuss like meds that were prescribed, treatment that was provided, any follow-up recommendations. But they also can mean if you're transitioning from like not only the hospital to home or from home to assisted living or wherever you might go, they would provide you with the resources to set you up for success and not failure, depending on the situation. But it's just a meeting with the provider to see what they can do to help you,
Okay.
be set up.
So basically, they can kind of help with post-discharge
Right.
check-ins, if there's any new or different symptoms that you may be having post-hospitalization, reconciling any meds that you may be looking at, and maybe possibly even identify some red flags. So they're kind of like an extra set of eyes and ears, would you say,
Mm-hmm.
for the clinic?
Yeah, for sure.
Okay. So who
Mm-hmm.
would qualify for transitional care? Like, is it something that's specifically like documented, like the primary care provider would say, institute transitional care or have them see transitional care navigator? How does that work?
It depends on the type of appointment. Like we use like the TCM thing for we mainly use it for those that are discharged after hospital stays. So most hospitals tell them like follow up with your PCP in 2 days. So that's when they would call us and we'd schedule that appointment. But if it was something more as like assisted living or memory care, usually then it's the family reaching out to us to tell us that they want to move forward with this. And then it's just them bringing their loved one in. And then it's kind of more just like mediating, you know, yeah.
Okay. So would you say that people who have multiple chronic conditions or are frequent flyers to the emergency room or have really complex, medical histories or new diagnoses would qualify for this type of care?
I think so. Yeah. Hmm.
Okay. All right. So do you specifically have like a complex care management model out of your clinic, or have you seen that, within your system? And you have to enroll in it.
Honestly, I'm not quite familiar
Hmm.
with that. I'm not sure.
And Linda, I can speak on that. I know with our clinic that feeds into our hospital in our area, that's one of the things that we've seen over the last 5 years or so really change is they'll have nurses like call people after, a hospitalization because maybe they're at risk for not coming to their doctor appointment, their follow-up appointment. But we see changes that they keep reducing the amount of clients they could see because they just don't have enough of these nurses to go around. So it's usually the most critical or the most at-risk patients for readmission to the hospital that actually get this transitional care. So it's a great system, but it's not always foolproof. And so a lot of times that's why, where Linda and I come in is we can help fill those gaps.
Hmm. Yeah.
Hmm.
Because if you think about it, there's a large population that has multiple chronic conditions, and the follow-up is very important. So having that ability to know that there's someone there, but I can see that where it's basically for individuals that are coming out of the hospitals because they're given 7, 8, 9, 12 pages of discharge summary, and if they're older and they're a poor historian and they're on multiple meds, they may or may not remember the things that they need to do to have somebody call and check in on them to say, hey, you have a doctor's appointment. Do you remember that? And did you pick up that prescription? Because we're seeing here that it wasn't picked up at the pharmacy. So I think those types of things for these complex cases are really, really important. And that is where Pam and I come in because there isn't enough of those individuals. And because we're independent, we can totally look at things from outside of that system and see if there's other resources that are available for them. So,
All right. Well,
let's wrap this up.
okay.
I think we've been talking for a
So,
while, Vicky.
yes. Yeah. So, Vicky, we're going to kind of just shoot some last minute things at you as we wrap up this podcast episode. We hope that it's been so enlightening for especially our new caregivers and very eye opening for maybe those that have some experience. So, is there one thing that you can think of that caregivers should ask their clinic this week?
I just generally speaking, like what resources that they can offer, because there's a lot that people are unaware of that clinics can do for them. But I think the biggest would just be like, who is the point of contact or who should I contact and how should I contact them if I need a question answered or whatnot? Because every clinic's different.
Well,
So
and then that leads me into my question. So, what's the biggest MyChart proxy access mistake that you see individuals make in using those systems?
Besides like asking about other patients within a certain like asking about like somebody's wife in the husband's chart. Besides that one, just sending paragraphs of things without a question or like I don't know how to explain it. Like yeah, just like sending a long thing and then saying you Googled it. Like that's not a lot of people like Google their diagnoses and that just, you know, instills more fear into them because it's not a provider
Mm-hmm.
telling them what is going on with
So
them. So
keeping it
I
short, sweet,
probably
to the
those two
point,
things.
with an
Keep it,
ask. What
yes,
is the,
with an ask.
yeah, and don't ask Dr. Google.
Yeah, don't. And then usually wait for the provider to reach out in regards to test results because those get released to the patient before the team even sees them. So we are going to see them. We get a notification of when they're put in the chart, but it might be 10 p.m. on a Sunday. We're not going to see that until Monday the next day. So give us like 24 hours to respond to you in regards to your test results.
That's really, really, and I'm glad you brought that up, Vicky, because that's a really good point to know that oftentimes you can see those labs, but I know when I look at, say, my own
Right.
MyChart, it will say these labs have not been reviewed yet by your physician. So, it's real important to make sure that when you're looking at those labs, your doctor will answer it if there's something
Right.
going on, good or bad. They're really good about that, but they may just not have seen them yet. And if a caregiver is overwhelmed, what's the fastest way to get through to the clinic?
Depends on the clinic. Probably just calling the clinic. My organization now switched over to PACT, which is a call center. So when you call the clinic directly, it routes you to like a nurse in Illinois, and then they can triage you or they can connect you to the clinic. So it's not great. We're still working through the kinks of that. So probably with my clinic, MyChart is the best if it's not urgent.
Mhm.
All right, so let's wrap this up. And so we want to make this practical for everyone. So your next step is to call your clinic and ask what supportive services are available and who is the contact person. Who should you be reaching out? So that is the first thing that we want to bring home again about this episode.
And then the next thing is if you don't have access to MyChart, get that set up or ask the clinic to help you set that up, especially proxy access if you're managing care for a parent or a spouse. That's really important.
And, if this episode has helped you, consider sharing it with a friend, a sibling, or a caregiver or a coworker who's caregiving right now.
Yeah, remember, caregivers don't get a handbook. And this is the kind of support that can make a really huge difference in the ability of caring for someone else because it's a big undertaking. So we want to thank Vicky very, very much for joining us today and sharing some of the best practices on how to best utilize your primary care clinic as a resource.
And, also make sure you subscribe to Healthcare Redefined, advocating for aging adults and their families so that you don't miss a single episode.
And if you have a minute, please leave us a review because it really helps us help more families find this podcast when they're searching for answers.
And we really want to thank you for being here with us today.
So you're not alone in this, and you don't have to figure it out all at once. We'll see you next time.
Take care.